Hi, everybody. Welcome to the Pelvic Health Explorers membership monthly interview. And we are so excited and lucky to have the amazing Jill Osborne with us from the IC Network. And she has some amazing information. I got a chance to hear her at the Pelvic Health Solutions Symposium about a month ago. And the information she presented, I just knew I had to bring her here. And I'm so excited that she consented to come. Jill, why don't you tell us a little bit about yourself and then we'll get started in with some of the amazing things you want to share with us today.
Well, I'm a pelvic pain patient, just like millions of other patients. And while I was diagnosed with interstitial cystitis, bladder pain syndrome in my 30s, it really began when I was a kid. So I had frequency urgency. I couldn't sit through class in 7th grade. My teachers used to, complain to my parents, and they would send me to the doctor, and they'd give me antibiotics, which never worked, yada, yada, yada. Vulvodynia in high school, irritable bowel in my early 20s, anxiety, migraines, and then finally severe bladder and pelvic pain when I was in my early 30s. And I was just saying earlier that the turning point for me when I went from being a passive victim to being like truly a warrior was when I had a doctor in the emergency room say to me that I would forever be a burden on my family, that this is my life, get used to it. I would always live with severe pain. And that was the moment I stood up and went, wait a second, wait. I've got 3 degrees. I've got an award from the White House. I will prove you wrong. How dare you say that to me? That's exactly what I said to him. And I went home and I started studying. That was 30 years ago. Today, the IC Network website has been rated the top website in 2 peer-reviewed studies. I am a lecturer for the International Continence Society, currently sitting on the guidelines committee for male pelvic pain. But most importantly, the best part of my job is finding patients who don't understand, who feel like it's their fault, who feel like they're damaged goods, and letting them know that it's not, and giving them a pathway to success. Now, what we're going to do today is we're going to be talking about phenotyping. And so let me go ahead and start my presentation here.
Okay, we don't see your slides yet.
You will in just a moment.
Sounds good.
Okay, how are we?
There we are. We're good.
All right. So who am I? My name is Jill Osborne, obviously. I've been a support group leader for 31 years. I built the first website on IC. I was allocating millions of dollars of IC research with the CDMRP research panel with the US Army, et cetera, et cetera. I do live support group meetings on YouTube and Facebook almost every weekend. And I do work with a lot of pharmaceutical companies and supplement companies and things like that. So what's our topic today? Phenotyping and the diagnosis and treatment of ICBPS. So what are our objectives? We're going to review the history of phenotyping proposals. We're going to review the practical application of phenotyping in your clinic using 6 case studies, and we're going to explore the value of phenotyping in patient education. But we're going to start by talking about 6 distinct patients, each of whom have been diagnosed with IC, bladder pain syndrome, or chronic pelvic pain syndrome. So let's go to our first one. We've got a 74-year-old female. She's got severe pelvic pain. She's had frequency urgency for the past 20 years. Her symptoms have worsened over time. She's got a poor quality of life, poor functionality, presents with severe depression, basically housebound. Cystoscopy finds several Hunner's lesions, wounds in her bladder. She's had fulguration and steroid injection multiple times, but the lesions keep recurring. She was on Elmeron for over 20 years with little effect, and she currently has eye damage, pigmentary maculopathy from that Elmeron. She's used antidepressants for well over 10 years, and she is very diet sensitive. And I know you've seen a lot of these women. Go to our next one. We've got a 38-year-old male, the U.S. Army paratrooper. He's got pain when sitting that's exacerbated when sitting, that gets better when he's standing. He's got pain at the tip of his penis. He has to strain to urinate, and he self-catheterizes occasionally. But he's got a normal prostate. Standard IC therapy is ineffective, and he's not at all diet sensitive. Okay, we've got a 30-year-old female. Her frequency urgency began in her teens. She's got persistent pelvic pain, especially with her period. She's got early onset endometriosis and has already had multiple surgeries. She's got IBS, migraines, pelvic floor dysfunction. She works as an attorney, at least she's trying to. It's very hard for her. She is very diet sensitive. And now we've got a 21-year-old male. Sudden onset, frequency urgency pelvic pain at the age of 18. He's got severe pain on bladder fill, prostate normal, dropped out of college, absolutely bedbound, very diet sensitive, very suicidal. We've got a 56-year-old female. Her frequency urgency began at the age of 54. She's got moderate nocturia. Her pain is described at the entrance to her urethra and in her vaginal introitus. She has pain with intercourse. She has pain on bladder fill. She can no longer enjoy a cup of coffee without discomfort. She too has diet sensitivity. Last but not least, we've got a 13-year-old female. She's got sudden onset frequency urgency. She can't sit through class without asking to use the restroom. Her urine cultures are negative. Urethral dilations were ineffective. She is very diet sensitive. So each of these patients have had a negative urine cultures. They were provided antibiotics with no effect. They were eventually diagnosed with interstitial cystitis or bladder pain syndrome. They were specifically told they had an incurable bladder disease, but they experienced a very poor response to conventional IC treatments. They continue to suffer with flares. So what do we know in 2024? Number one, the IC patient population is remarkably diverse, including age of onset, their culture, their profession, and their history. We know that a one-treatment-fits-all approach, such as Elmeron, does not work for the majority of patients. And we also know that the U.S. National Institutes of Health has invested more than $100 million in IC treatment, and only one study was found to be significantly successful: pelvic floor physical therapy. So if physical therapy is successful when other bladder therapies are not, is this really a bladder disease? So let's take a quick history, shall we, at the perceptions of IC and how they've changed over time. So what's our early history? In 1836, Parrish described IC as tic douloureux of the bladder. He wrote, quote, "I have known great suffering in the urinary organs from this form of disease." And his assumption was that this was a neuralgia of some type. In the 1850s, Physics and Byrne described patients with a mysterious bladder pain in which no bladder stones were found, because back then, because their diets were so high in salt, there were a lot of bladder stones. Also in the 1850s, Gross described inflammation of the bladder wall. He wrote, quote, "The chronic form of the malady entails a vast amount of suffering, which, continuing for months and perhaps years, finally saps the foundation of life." Now in 1915, Dr. Guy Hunter, with the use of the brand newly developed cystoscope, identified ulcers on the bladder wall in some, but certainly not all patients. Those ulcers are now known as Hunter's lesions. In the 1940s, Hand described small discrete submucosal hemorrhages and dot-like bleeding points, which we call glomerations or petechial hemorrhages, that he believed was this mysterious bladder disease. However, if you look at our most recently updated AUA guidelines in 2022, they have been thrown out as being meaningful for IC because they are not specific to IC. They're basically an adverse event from having a hydrodistension, that when you stretch the bladder, you break the skin and you cause mucosal hemorrhaging. Now in 1987, the US National Institutes of Health created their first guidelines for IC, in which the diagnosis was confirmed only by the presence of Hunter's lesions or glomerations. And back then, those guidelines quickly became status quo in clinic also. However, research later found that 60% of patients did not have Hunter's lesions or petechial hemorrhages. So again, if this is the case, is IC really a bladder disease? Well, clearly it isn't. And so the very first conclusion that researchers made, and IC experts around the world made, is that there are at least two patient groups: patients with Hunner's lesions and patients without Hunner's lesions. And what's interesting about a Hunner's lesion is when you biopsy them, it is gross inflammation on biopsy. There is a biological war happening in that Hunner's lesion. Now, in 2001, Dr. Jerome Weiss, who is a true hero of mine, was one of the first urologists to expand his practice to include the assessment and treatment of muscles. His first study showed that physical therapy was remarkably successful, that 45 women, 7 men with IC or urgency frequency syndrome had manual physical therapy for 8 to 12 weeks, and 83% had a moderate or marked improvement, and their resting pelvic floor tension decreased from 9.7 to 3.6. Yet, this was essentially ignored by mainstream urologists for many years. Now, in 2003 to 2007, another hero of mine, Rhonda Cotterinos and Mary Pat Fitzgerald, published one of their first protocols to rehabilitate hypertonic pelvic floor muscles found in bladder and pelvic pain patients. And I'm going to say, what's so interesting is when you go back in history and you look at the early descriptions of IC, they pretty much all say tight muscles that resemble tight piano strings. And yet, despite that very, very consistent finding, urologists didn't mean anything to them. So here we have Rhonda Cotterinos and Mary Pat saying, hey, let's see if we can address those pelvic floor muscles. And at the same time, Dr. Ken Peters, another hero of mine, demonstrated an association between IC and pelvic floor dysfunction in a study of 70 women. In 2008, the European Society for the Study of IC, which is now known as the International Society for the Study of Bladder Pain Syndrome, released their consensus statement on IC, which they defined as a bladder disease. Now, they required a hydrodistension and a biopsy of the bladder wall, and then they ranked their patients based upon what they found. So they were the first to be somewhat open-minded and saying, hey, look at that. There could be many, many different variations of this. The flaw with their system is that they required hydrodistensions on every patient, and that's simply not viable throughout the vast majority of the world, and certainly not viable here in the United States, where we have insurance companies who will not pay for that. Here in the United States, hydrodistension is only performed if the diagnosis is in doubt. However, we have new, more effective, flexible cystoscopes that can be done in clinic without hydrodistension that could at least identify Hunner's lesions. Interestingly, in 2009, the Japanese and East Asian guidelines were released, and they were the first to use the term hypersensitive bladder syndrome. They suggested that bladder hypersensitivity is associated with urinary frequency and bladder pain. So they were the first to discuss in depth the concept of neurosensitivity in the IC patient population, and boy, were they right. So in 2009, we had our first big treatment breakthrough. And of course, that was the release of the NIH study on pelvic floor, which showed that 57% of patients responded to pelvic floor physical therapy, whereas only 21% responded to general massage. So this was indeed the most important first turning point, a validated study that proved that physical therapy was in fact more successful than oral medication. So again, I ask you, if IC was a bladder disease, why would physical therapy help? Now, in 2009, we have our first true phenotyping proposal. It was called UPoint, and it was developed by Dr. Dan Shoskis and Curtis Nickel. They encouraged doctors to create a customized treatment plan based upon 6 key domains: the patient's urinary symptoms, their psychosocial functioning, i.e. depression, catastrophizing, based upon their organ-specific findings. Are there Hunner's lesions or not? Is there a history of infection? What their neurological health is, and muscle tenderness. And then a patient's treatment plan would be based upon that doctor's findings. UPoint was eventually adapted to a new system called Input, specifically for the bladder, and is currently recommended for the use with the Canadian Urology Association guidelines for IC, but those are currently being updated, so we don't know what they're going to say yet. So what did we, the patients, think? We were ecstatic. I remember talking to Dr. Shassis going, finally, someone's willing to look at the totality of our body. That this was the first time somebody addressed widespread pain, which we all had been discussing for so many years. You know, the connection between IC and IBS and vulvodynia. But why do so many patients have very sensitive skin or a wicked sense of smell, which of course we now recognize as a sign of central sensitization and widespread pain? So this was the first symptom that truly emphasized the development of an individualized treatment plan. And let me just say, was it adopted? No. By most of the people in the world, no. The organ-specific physicians were still clinging to the organ-specific model. Now, in 2011, the American Urology Association guidelines for IC were released, which reflected some but not all of these changes. You know, they're very slow. They want a lot of research first. So they referred to IC as an incurable bladder disease, but they did add a pelvic floor muscle assessment and referral to physical therapy to their treatment plan. So this did indeed expand treatment from oral therapies and bladder installations to manual therapies. But please note that in the latest guideline from AUA, they now say that no bladder disease is found in the great majority of IC patients. They focus instead on neuromuscular origins. We now estimate that 85% of the IC patient population is probably neuromuscular in origin. However, we have one flaw with this system, and that is, do urologists read the guidelines? And the answer is no. The great majority of practicing urologists at the local level, at the regional level, they're still treating IC out of old textbooks. They're still focusing on bladder therapies and oral meds. So let's go to the system that I personally use today, which is Christopher Payne's 5 phenotypes for IC. Dr. Payne is a professor emeritus from Stanford University. He was a federally funded IC researcher. He chaired NIH meetings, and he did a lot of IC research at Stanford. So his rationale was very interesting. He said, listen, a diagnosis of IC doesn't give the patient or the provider a clear treatment pathway. And as a model, he says, let's look at the far more in-depth diagnoses provided in cancer care, arguing that they have a clearly identifiable treatment plan. Yet, a diagnosis of IC leaves both the patient and the physician pretty much unsure of what to do next. And he says with phenotyping, IC patients can receive a more accurate diagnosis and a more effective treatment plan. And he proposes 5 distinct patient groups, each with their own treatments, but he also suggests that there are probably more. So in his system, group number 1 is Hunner's lesions. Profound inflammation on biopsy, they've got extreme symptoms, extreme diet sensitivity. Here's the kicker. Multiple studies have now found virus in the urine of these patients, polyoma BK, polyoma JC, Epstein-Barr. That helps us understand why there's such severe inflammation in the bladder. Now, fascinatingly, while that original research came from Europe, the Americans were amazingly silent for about 5 years. But what we didn't know is that they were doing their own viral study. The NIH MAP Research Network had samples of urine from hundreds of patients who had participated in their study, and they went back and they looked at those. And what did they find? Virus in about 5% of patients. So when you're thinking UTI, Stop thinking just bacteria. We want to start thinking about virus, and we want to start thinking about fungus. There is one other very interesting potential cause of Hunner's lesions, and that is posterior fornix syndrome. Now, if you've never heard of that before, basically what that means is that one of the ligaments that holds the uterus in place has broken. So now we have a uterus that has flipped. The back is facing the front is facing the back. And if you go back and you look at the early posterior fornix research, they talk about how that also can affect the bladder. So what's our therapeutic priority for these patients? We're going to do lesion-specific therapies, fulguration, laser therapy, steroid injection, hyperbaric oxygen therapy, but antivirals are currently being studied, and we have a brand new study that shows that lactoferrin also appears to dramatically improve inflammation in the bladder wall and basically heal Hunner's lesions. They're almost completely resolved. For these patients, consistent pain monitoring and multimodal care is essential. These patients must follow the IC diet because they have open wounds. The number one cause of severe pain in the IC patient is an untreated Hunner's lesion. I was just working with a patient yesterday. When that doctor finds a lesion, the AUA guidelines say they should be treated immediately. We should not be sending these patients home with an open wound in their bladder. Of course, that's going to hurt. Let's go to our second group, bladder wall driven. So in this group, we've got a couple of variants. We've got chemical injury to the bladder, because the bladder, like any other part of the body, can be hurt. It's going to be hurt through chemical exposure, like chemotherapy. You know, the caustic chemicals in chemo are well known to damage the bladder wall, but so can ketamine, a recreational drug that's become a lot more popular, as well as, of course, excessive drinking of soda, coffee, energy drinks, etc. The second thing we're going to look for in this group is genitourinary syndrome of menopause, because as estrogen levels drop, the bladder wall's ability to produce that protective mucus diminishes. The bladder becomes more vulnerable to irritation from urine. That is not a disease process. That is just aging. These patients should not be told they have an incurable disease. That is not fair to them. And of course, we have to explore the role of chronic infection, because if there's ever a group of patients massively overexposed to antibiotics, it is the typical IC patient. And what happens when we take antibiotics? We kill the good bacteria, which allows fungus and candida to grow. We now have research, again from the National Institutes of Health, which has correlated the presence of candida in the bladder with increasing levels of bladder pain. So what are our therapeutic priorities? We're going to remove the irritants. We're going to address the skin health and GSM with topical estrogen. We might use some oral medications like palmitoyl ethanolamide, which is a supplement, amitriptyline, but we want to be cautious of Pitocin because pigmentary maculopathy and inflammatory bowel disease. We might be doing some bladder installations with these patients, but the American Urology Association encourages the use of supplements because they have less risk of adverse events. So they want patients to try the least risky things before you go to the more risky things, again, like Pitocin and its role in causing retinal damage and blindness. What's our third subtype or phenotype in the pain system? Pelvic floor driven. So these are patients who have a previous history of pelvic trauma, car accidents, falls. They may have a history of childhood or extreme athletics or dance. They may have suffered injuries during childbirth. They may have suffered sexual abuse. And for many of these patients, their symptoms often begin at a young age. And for these patients, we know the devastating toll of tight pelvic floor muscles over time is pelvic ischemia. So what are our therapeutic priorities for these patients? Well, number one, we're going to obtain a comprehensive pelvic floor assessment by a properly trained physical therapist. Our goal is to restore muscle tone. Healthy muscle feels like a raw chicken breast. It's soft, but it has substance. Tight muscle feels like a cooked chicken breast or an overcooked chicken breast. And a badly damaged muscle is going to feel like beef jerky. That's a really good example to give to your patients. We want to address trigger points with manual therapy and trigger point injections, but If muscles are returning to chronic tension, we must address the underlying skeletal problems, the SI joint, the tailbone, the hips, the knees, and in many cases, the feet and how their foot hits the ground. Patients should be taught to recognize tension early and treat with stretching and internal massage, or in my case, I use my wand. What's our fourth phenotype in the pain system? Pudendal neuralgia. This is driven by nerve injury or dysfunction. So these patients are going to demonstrate positional symptoms. Pain when they sit, that gets better when they stand. Pins and needles, numbness, PGAD, or fasciculations. This is often the result of tight muscles compressing nerves, such as sciatica. We often see a history of bike riding, horseback riding, motorcycle riding, or if they're riding a desk for long periods of time and sitting for long periods of time. So what are our therapeutic priorities for these patients? We're going to identify the compression location. We're going to reduce contracture and restore normal tone with physical therapy. We're going to calm nerves topically and internally with topical anesthetics like lidocaine, nerve blocks, and nerve calming medicines like PEA, Neurontin. And most importantly, we're going to avoid those things which put pressure on those nerves, such as bike riding, sitting for long periods of time, and other triggers. Now let's go to his final phenotype, central sensitization. This is the most important thing. These are patients who have widespread pain like me. And if they have two or more of the chronic overlapping pain conditions, that is their diagnosis. So that's IBS, vulvodynia, TMJ, fibromyalgia, migraines, et cetera, et cetera. These patients have extreme sensory sensitivity. They've got sensitive skin, a sensitive sense of smell, of taste, of sound, of light. I can remember as a child, I used to complain about the bright lights in one room in my house. It was really quite frustrating for me how uncomfortable it was. These patients will have food, chemical, or drug sensitivity, and they're going to have a lot of anxiety disorder and catastrophic thinking. So what is this? This is, in fact, a dysfunction, an injury, a maladaptation of the central nervous system. And the origin is in trauma. The adverse childhood events are strongly linked to the development of chronic and widespread pain. And what's interesting, if you look at the Chronic Pain Research Alliance, they're the ones who first started studying the nervous system in depth, as well as the brain. And eventually our National Institutes of Health did that too. And this is what they found. Patients with widespread pain, their brains are in a constant state of fight or flight. I was in this group. So this is not a mental illness, but rather the result of a nervous system injury or trauma. Now let's look at the MAP Adverse Childhood Events Study. That's the NIH study. This 2008 study found that adverse childhood events was elevated in 421 IC patients when compared to healthy controls. The adverse childhood events are associated with complex chronic pain, pain syndromes, and perceived well-being. And the more severe the history of adverse childhood events, the less likelihood of improvement and worsening of pain symptoms. So what are our therapeutic priorities for this phenotype? We have to turn the amygdala off. And we do that by telling and training the brain that they are safe. How do we do that? With mind-body medicine techniques like tapping and I spy. The language of fight or flight is sensory. You can't cognitively tell your brain, hey, turn off fight or flight. It doesn't work that way. We have to prove to the brain that we're safe with good sensory input. We have to address anxiety and catastrophizing, which just reinforces fight or flight. The challenge here is that patients get stuck in this cycle. The more anxious they get, the more they scare their brain, the more fight or flight they're in, and they're in this vicious cycle. We have to embrace positivity. Pain that is accompanied by laughter is minimized by the brain. Pain that is accompanied by anxiety and tears is exaggerated, intensified by the brain, because the brain thinks your life is a state. And interestingly, we've got some new upcoming research led by Dr. Jason Kutch down at USC, where they're starting to do some brain nerve stimulation. And I was just reading a study with him where they're doing like a surfing app, something like that. I asked Dr. Coach when I was interviewing him, because he has widespread pain too, what do you do when you feel your central nervous system amping up and you're starting to struggle with pain? He said, I surf. I go surf. He said, because when you're surfing, your brain is so focused on the water and the wind and balance and standing. He said, that effectively turns off fight or flight. You're forcing your brain to be in the moment. Fascinating. So, why have so many research studies failed? Why have pretty much every bladder treatment study ever done, millions of dollars, more than $100 million, probably 3 times that? Every one of those studies failed with the exception of the physical therapy. Why? Well, we believe that this is the group, that it's the widespread pain group, including widespread pain patients in a study on bladder therapies is inevitably going to tank that study. And we have a brand new study, again from the MAP Research Network, that just came out last month that showed that patients with local pain respond best to local therapies. Patients with widespread pain respond best to centrally acting therapies. So they suggest, and we all suggest, and I suggested 5 years ago, that future clinical trials should differentiate patients based upon the presence of widespread pain. Because research is slowing down, because companies have walked away because they failed. The way we're going to get them back involved is if we give them an early on-ramp to success. And the way we do that is by making sure they're phenotyping first. So what are the advantages of the pain system? Well, it's ideal for use in clinic. It's really easy and simple to explain. It provides an intuitive treatment plan for each patient. It helps the patients understand the value of a multimodal approach and validates the use of specific therapies, such as topical estrogen for estrogen atrophy or antidepressants to calm the central nervous system. Most importantly, it puts self-care and mind-body medicine into context without offending those patients by suggesting that their symptoms are all in their head. Now we come to the king of phenotyping, Dr. Curtis Nickel up in Canada. Curtis Nickel has long been considered one of the best IC researchers in the world, and he is also a brilliant author. I read everything that he's ever written. He's just so insightful. So in 2022, as he approached his retirement, he wanted to leave his legacy. He believes that there are 9 groups of IC patients. Now, I don't know if anybody is using his system, but again, the Canadian Urology Association in their updated guidelines will probably go in this direction. So what's his rationale? He's passing on his wisdom. He said, I've been asked by urologists many times over the decades how to treat a patient with IC, and I found that I gave a different answer based upon each patient's clinical picture. He said also, a stepwise one treatment fits all approach is doomed to failure in the majority of patients. So he now has 9 distinct groups. Group number 1, inflammatory, also known as Hunner's lesions. And so he doesn't differentiate from anybody else. He said these need to be cauterized multiple times if necessary. He switches to steroid injections into the lesion. For mild recurrences, he suggests using a classic rescue installation. And for patients who do not respond to treatments, he goes for oral cyclosporin. What's his second group? Infection mediated. Now, this is interesting because no one else is talking about this. He argues that there are patients who have a history of recurring UTIs who may be experiencing a bladder hypersensitivity syndrome secondary to the infection. So for these patients, he suggests giving them the antibiotics, but not orally. Put the antibiotics directly into the bladder with a bladder installation. He is strongly supportive of the new UTI vaccines, including MV140. He's been a researcher in that. And he also believes in the value of next generation DNA urine testing and finding rare and more challenging infections, especially fungal infections. His third group is neurogenic hypersensitivity. Hello, widespread pain. And for these, he suggests the use of low-dose antidepressants, although we all know that those are very difficult for patients to tolerate, and I, for one, was not able to take them. He suggests bladder installations to support the gag layer and the use of lidocaine in installations to calm the superficial nerves in the bladder wall. His fourth group is multiple allergies. These patients have multiple respiratory, environmental, or dietary allergies. This is so interesting. He said, you know what? These are really easy to identify if you just poke their bladder wall with the cystoscope. If that causes the development of a mucosal wheal, you've got a patient who's got potentially a mast cell issues, and these are the patients that we're going to target with antihistamines, and maybe rescue installations might help a little bit until we get the histamines under control. Obviously, very clear, the biggest group is pelvic floor pain, and it doesn't change from any of the other things we've talked about earlier. Physical therapy is a must. His sixth group is primary storage symptom syndrome. These patients run to the restroom due to pain on bladder fill, and for these patients, he wants antimuscarinics to be used once the pain has been controlled, but we've got to control the pain first. Ideally, mirabegron, which is not an anticholinergic, therefore not linked to cognitive decline. We want patients to do perhaps some bladder training to increase capacity, Botox, and he also does not believe that neuromodulation will significantly reduce the symptoms in this patient population. Now here's something new that nobody else is talking about, urethral pain syndrome. This is patients who only have pain in the urethra as their symptom. Their pain can be constant, episodic, or associated with urination. He believes that these are the most difficult patients to treat. He suggests topical lidocaine to numb the urethra, vaginal estrogen, local or oral amitriptyline, but that local Amibac creams, a diazepam, periurethral block, etc. Sexual pain. Pain with intimacy must be addressed in patients who are sexually active, where the location of pain must first be assessed. Is it coming from the vagina, the vulva, the pelvic floor, or the bladder? Treatment is with pelvic floor physical therapy, but perhaps some topical lidocaine and topical estrogen will help improve the skin and calm the nerves down. And last but not least, IC flares. IC flares require additional care. They can be triggered by diets, menstruation, stress, infections, inflammation, intimacy. They can last for hours to days. And of course, we have the typical flare management strategy. And he emphasizes here stopping irritating vitamins and supplements such as cranberry and vitamin C. He also added, for many, many years, he had a Friday clinic in the afternoon for patients to come in to get rescue installations to help them with flares over the weekend so that they could enjoy their weekend. So what are the advantages to the nickel proposal? Well, takes a deeper dive into other causes of pelvic pain, particularly urethral pain. He reminds us all that flares require treatment. His recipes for treatment are thorough and customized for each phenotype, and he focuses on a critical patient need, the management of flares. All right. Most recently, the AUA 2022 guideline. Finally, the powers that be here in the United States go, oh, yes, there are patient groups. They're not willing to go to 9. They want more research, but they're willing to go to 3. They can basically combine some of the ones in the pain and the nickel system. So they believe that there's a bladder-centric group. So those are going to be the Hunter's lesion, the estrogen atrophy, et cetera, et cetera. We've got the pelvic floor group, and we've got the widespread pain group. So what is their treatment approach? Well, the AUA says no single treatment works for the majority of patients. Treatment must be tailored to the specific symptoms of each patient. And if a patient is not responding to multiple treatments, the diagnosis of IC should be reconsidered. We no longer want patients to continue meds that are not working. We don't want that patient to experience severe financial distress, as many did because the cost of Elmiron was so high. So AUA only has 2 treatment recommendations. Number 1, Hunter's lesion should be identified and treated promptly with lesion-specific therapies. And for you, patients with pelvic floor tension should be referred immediately to physical therapy. All of the other treatments are considered options. Now, again, in Canada, we don't know what's going on in Canada right now. All right, so the clinical application of phenotyping. So how are we going to use these in clinic? Let's go back to our 6 patients, shall we? So we've got a 74-year-old female, severe pelvic pain, symptoms have worsened over time. Cystoscopy finds Hunter's lesion. So what is her phenotype? Easy. Hunter's lesions. Now, as she's older, she's got some genitourinary syndrome of menopause. She's got to work on her skin health. Obviously, because she's been in pain for a long period of time, she's going to have pelvic floor dysfunction. And here's what's interesting. Testing confirmed she had an active Epstein-Barr infection, which probably caused the lesion. So she's currently using antivirals, estrogen, physical therapy, and pain care. And I just worked with another patient yesterday who is 44, diagnosed with Epstein-Barr 4 months ago when her IC symptoms began. Fascinating. Let's go to the guy here, 38-year-old male, paratrooper. Pain with moderate pelvic pain exacerbated by sitting, pain at the tip of his penis. He's not diet sensitive. What does that tell us? He's got a healthy bladder wall. Look at his career, paratrooper. He was one of my clients. Like, sir, do you ever suffer any pelvic trauma? Yeah. I said, you ever fall on your tailbone? He goes, yeah, a lot. And I said, and he goes, I went, okay, what was it? He goes, I'm a paratrooper. I can't tell you the number of hard landings I've had. Okay, this is a pelvic floor patient who also has pudendal nerve entrapment. So he is a trauma patient. And his treatment is going to be focused on pelvic floor rehab combined with nerve calming treatment. I can still remember another gentleman I was working with. He called and he said, every time I sit down, my pelvis vibrates so badly, it almost throws me off the chair. And that is a really severe example of a pudendal nerve entrapment. Let's go to our 30-year-old female. Her symptoms began as teen. She's got persistent pelvic pain. She's got endometriosis, diet sensitive. What's her phenotype? Well, this is interesting. A new study of 533 IC patients found that 20% have a history of endo. These patients have a large bladder capacity. They report chronic pelvic pain, fatigue, migraines, pelvic floor dysfunction. This is a non-bladder centric phenotype, aka a systemic pain disorder. So their treatment, her treatment, is going to be focused on systemic therapies. Now let's go to our 21-year-old. This is a trick one. Sudden onset of frequency urgency, severe pain on bladder fill, prostate normal, very diet sensitive. What's wrong with him? Well, when they looked at his bladder, he's got severe bladder inflammation. Patient confessed that he's been using ketamine and that he noticed blood in his urine after using ketamine. So he has a bladder wall driven chemical injury, and his treatment is focused on addressing the addiction to ketamine, managing symptoms while the bladder heals. And while traditional IC therapies may be helpful, though all is not if he continues to use ketamine. The IC network is the only group in the world that does support for patients with ketamine. Let's go to our 56-year-old female. Her symptoms began at the age of 54. Big giant clue there, moderate nocturia, pain at the vaginal introitus, in the urethra, on bladder fill. Yet her bladder is completely normal on cystoscopy. What on earth is going on with her? Easy. She's got estrogen atrophy, genitourinary syndrome of menopause. Her priority treatment is going to be topical estrogen. And this is a patient specifically that's going to benefit from bladder coating therapies. She would have been ideal for Elmeron, but of course now Elmeron, we have issues with Elmeron. So these patients instead have converted to chondroitin-based supplements to support the bladder wall. And that's going to be Bladder Builder, Bladder Rest, Cystomend, or Cystoprotect. But she also might find topicals very helpful. specifically vulva balm, a very, very light oil base, which is hydrophobic, which pushes urine away from that skin, because a lot of these patients have what I call urine burn. When they pee, their urine feels very, very hot. And that's just estrogen atrophy on the vulva. And so if we use something like vulva balm every day to just give that skin a little bit more of a protective coating, then urine is not going to tweak the nerves and not going to cause such superficial irritation. These patients might also benefit from topical lidocaine, and they can switch to coconut oil too. The problem with coconut oil is it just soaks through everything, and it will soak through your clothes. It will go from your underwear to your jeans, and before you know it, you have an oily wet spot that makes you look like you wet your pants. These patients might benefit from rescue installations if they're in a big flare, mirabegron to control frequency urgency. Also really understand that these patients, because they don't have healthy skin, may also struggle with recurring UTI. If they've had 2 infections in 6 months, 3 infections in a year, that is a recurring UTI patient. Priority of treatment there is to get that skin as healthy as possible. And so we'll make sure that this patient is using topical estrogen combined with the appropriate antibiotic. Understand too that a lot of women stop topical estrogen because they just don't understand why it's important. They go, that's not working. Why am I taking it? All right, let's go to patient number 6. Look familiar? Hello. This is me. My symptoms began in 7th grade. I couldn't sit through class without asking to use the restroom. My urine cultures were negative, but they gave me massive antibiotics anyway. I endured dozens of urethral dilations when I was in junior high, 1 a month or more. And I was very diet sensitive. So what's my history? So my first diagnosis is so interesting, was a urethral stricture. That's why they did the urethral dilations. And of course, back then, they basically shoved a metal sound up to the urethra and stretched it open. But nobody ever asked, gee, why is your urethra tight in the first place? Hello, tight pelvic floor muscles. I had vulvodynia in high school, polycystic ovarian syndrome, IBS, migraines, etc. in my 20s. And yet my bladder was always normal on cysto. Bladder therapies and antidepressants were ineffective. Finally, when the research came out in 2008 about physical therapy, I went and had a pelvic floor assessment. And guess what? My muscles were as tight as a drum. I suffered a tailbone injury at the age of 13. I broke my tailbone the year that my symptoms began. So that is why I ended up with urethral stricture, in my opinion. So it's very, very important to probe your patients for injuries and trauma, but just remember too, they may not remember it. But the key question is, why did I develop widespread pain? So here's the part of my story that shocks a lot of people, and that is that I was attacked by a kid who hurt many people. He was very mentally ill. I was attacked in 4th grade. I was afraid to go to school for a decade. My safe place was at home. As a teen, he raped and murdered my neighbor. We all knew it was happening. This was a kid who was killing animals. He was attacking everybody he could. He attacked me many times. And my brain recognized that threat early. I didn't understand it, but my brain knew I was there. I was in fight or flight for 25 years. I didn't get out of fight or flight until I took an anxiety management class when I was 35. And I still have moments when I struggle. If I travel, my brain's always saying, go home, go home, go home, go home. It is hardcore programmed into my brain that I'm safe at home, and I have to work on that. So what are the questions for patients with widespread pain? You need to ask them, can you remember any physical injuries when you were younger? Because 80% of the kids who develop widespread pain as adults have a history of injury. Were you abused or bullied? Were you a victim of sexual assault? Did you live in the home of an alcoholic? 20% of the patients have this history. Do you have sensitive skin? A wicked sense of smell? Key signs that we're dealing with a sensitive nervous system. Do you struggle with anxiety and catastrophic thinking? I did. These are all signs of central nervous system sensitivity and trauma. So why did I get better? Well, number one, I stopped blaming myself. I thought it was my fault for even through grad school. Getting a master's degree in psychology, I still thought it was my fault. But it was never my fault. It's not what's wrong with you, it's what happened to you that matters. I took a fabulous anxiety management class when I was 35 that stopped the constant panic attacks and fear that I had lived with for many, many years. Once I lowered those adrenaline levels, all of my symptoms calmed down. But I also massively embraced positivity. My home is filled with light and love and inspirational things everywhere. But because my brain will always remember that trauma, I use techniques that will calm my central nervous system and turn off my amygdala daily. Therapy, counseling, and support can be beneficial for those with severe trauma, but never suggest that this is all in their head. This is a natural and normal response to severe trauma. I'm starting EMDR therapy on the 20th to deal with the trauma from when I was a kid, because I want to go enjoy life. I want to go take a vacation and not think all the time about coming home. Okay, so what other phenotypes might be included? We're almost done here. Well, we know that there is a correlation with autoimmune disease in a small percentage of patients. So there might be another autoimmune subtype that needs to be defined. Hormone dysfunction, there's always been a group of patients, doesn't matter if their estrogen are high or their estrogen is low, they flare. And once they get their hormones stabilized, their symptoms improve. And of course, we need a clear understanding of the role of bacterial, fungal, and viral infections, also known as urinary biome abnormality. And this, my friends, I'm going to blow your mind. This is the last part of my presentation. Is there a remote chance that there is a smoking gun bacteria similar to the Helicobacter pylori in stomach ulcers? Now, that's what everybody has assumed all of this time, that maybe there's a newly undiscovered bacteria that could be triggering these symptoms. Of course, now that we do biome testing with next generation DNA urine testing, we've had many studies of the IC patient population. And here's what they found. We have less diversity of normal bacteria, and we have an abundance of lactobacillus. Well, lactobacillus is good bacteria, right? So it's not showing anything funky. But here's somebody you need to follow, Dr. Anne Lenore Ackerman at UCLA. She is a biome specialist, and she has made some interesting breakthroughs. So she heard about IC. She heard about these studies with a less diverse biome, and she thought, you know what, I'm going to take a closer look at that. So she did her own study. And at first, she made exactly the same finding: less diversity, more lactobacillus. But then she looked at the data based upon patient age. And what she found was patients with pain on bladder fill who were under the age of 45 were dominant in lactobacillus. Patients over the age of 60 with bladder pain had a lot more diversity. They had more E. coli, Gardnerella, Corynebacterium, etc. Then she looked at the biome based upon phenotypes. And here's what she found. Patients who were pelvic floor driven, again, 85% of patients most likely, everything's normal. Absolutely normal biome. Patients with pain outside of the bladder were dominant in E. coli and other bacteria, but patients with pain on bladder fill were dominant in something new. Write this down: Lactobacillus iners. INERS, Lactobacillus iners. So what is iners? It's a newly discovered lactobacillus, and it was found after somebody put blood in a growth medium. And it has already been associated with other urinary disorders, including overactive bladder. It is pathogenic. It is a gram-negative lactobacillus found in patients struggling with dysbiosis and cancer, and it makes a toxin that breaks down epithelial barriers. This is not a good lactobacillus. This is a pathogenic lactobacillus. It does not kill fungi or E. coli growth. It's not a good thing. It's associated with poor long-term outcomes. The other thing we have to understand is that increased fungal levels are also found in patients with IC. And of course, bladder pain increases as candida increases. And if the dominant lactobacillus is lactobacillus, and lactobacillus doesn't control fungus, that would explain why some patients are struggling with candida infection. So INRS associated with poor long-term health. It's related to higher levels of inflammatory markers. It is an opportunistic lactobacillus that appears to dominate the biome after antibiotic use. And of course, we certainly know that most IC patients have been provided extensive antibiotics over the years. So is lactobacillus INRS a smoking gun? It could be for a small number of patients, not all of them, but some of them. So Dr. Ackerman, in teaching the class on AUA the last 2 years, this year in particular, she ended her presentation by pretty much begging doctors to stop prescribing antibiotics for flares or UTIs when there's no finding of bacteria. She wrote, there are systemic effects for antibiotics, which might include the enrichment of species like Lactobacillus INRS and the overexpansion of fungal species like Candida. These may have long-term, very long-term, bigger consequences that we must all keep in the back of our heads. A lot of research, so I've got all the research here if anybody wants to look at that. So, is IC a bladder disease? Well, only patients with infection or inflammation have a disease process. There are distinct patient groups and phenotypes. Most patients diagnosed with IC have a neuromuscular influences, 85% with pelvic floor dysfunction. But urobiome studies must be expanded to help us understand the role of Lactobacillus INRS. We are long past the days of treating IC with Pitocin and antidepressants and sending them on their way with a copy of a diet. Phenotyping will identify a more effective approach to treatment. And that's it. Thank you, my friends. Thank you for listening. And thank you for working on behalf of those patients who have been suffering for years. I will tell you, I have phenotyped hundreds and hundreds of patients now, and it works, and it works well. So how about if I stop screen sharing now and I'll go back?
That would be great. Thank you.
There you go.
So that was fantastic. As always, listening to you is a privilege, and this information is going to help so many people. And I think it's really going to guide pelvic health physical therapy a long way to understand why we use the questionnaires we use, understand why we ask questions of our clients of what the plan is and what plan they're on. Is it helping? Is it effective? What's going on? How can they communicate with their healthcare providers a little bit better? And that working with the muscles and ligaments and bones and joints also have an impact. And I think all of this is just fantastic. But this is why in pelvic health physical therapy, it's essential. We really step into the biopsychosocial world. So, because it's not just bio, we've got the other parts to consider and how to help people. Thank you so much.
Yeah, so Dr. Jerome Weiss just released a brand new book. So he's kind of the leading pelvic pain doctor in the United States, but he's retiring at the end of this year. He just flat out said the new front line for pelvic pain care is you, physical therapist, because you're the ones who are embracing pain neuroscience. And he has been trying to create pelvic pain centers of excellence by getting clinics, organ-specific clinics, to bring in other modalities, to embrace the concept of widespread pain, central nervous system. And if anything, they're getting more extreme. They're just clinging to bladder stuff without understanding pain processing. And when you put it in the context of widespread pain, and you put it in the context of adverse childhood events or injury, and you explain to that patient, gee, you know why you have anxiety all the time? Because your brain is in fight or flight. And almost all of them say, yeah, absolutely. I completely agree. I'm in fight or flight. That then puts into context why it's so important to embrace better anxiety, whether they're taking they're taking a class on anxiety management or whatever, we gotta calm that central nervous system down. We've gotta calm that anxiety down. I just want to do a little shout out here. This is Dr.
Oh,
Weiss's book,
yeah.
Breaking Through Chronic Pelvic Pain. What I love about this book are all the case studies, and they're truly physical therapy case studies. These are patients with a wide variety of pelvic pain conditions where he's talking very specifically about a stepwise approach of how do we calm the nerves down. One of the things he does, he loves topicals. He loves topical lidocaine. Absolutely. Like I have fasciculations in my left butt cheek by my left sit bone. He's like, you need to be using your lidocaine more. I'm like, all right, I will. Subcutaneous lidocaine injections, although finding a doctor to do that, very, very difficult. But anyway, this is the book which really helped me understand how to do my internal pelvic floor work because it helped me understand the J shape.
Mm-hmm.
It helped me understand locations. So for patients with pudendal neuralgia and patients with a history of injury, I always encourage them to start. I mean, there are other books too. This just happens to be a book that I found personally helpful. So anyway, I hope I helped. Thank you
Yes.
for inviting me.
And, coming from the place that you come from and how you have embraced the studies and really help the people who are suffering, the people who have the issues, is huge because if a book appeals to you, it's going to appeal to our clients. This is the kind of information that we should all be sharing, not just as healthcare providers, but inclusively, including the people who have taken the journey and have done their own work and have empowered themselves to become our best teachers. And I've always said that when people say, what class should I take? What should I do? And it's like the person in front of you will help you more than anyone else because listen to their story. They'll tell you everything that's going on. And
Yeah.
this work with the phenotypes and how you present it is exactly that, telling a story.
So our challenge right now is with social media and specifically with TikTok, people don't want to read anymore.
Right.
Like websites are dinosaurs. Getting somebody to come to my website and read an article, very, very difficult now. They want short form video. And I've had patients say this to me. They say, don't tell me to read anything. I don't want to read anything. Just give me a video. So on one hand, we have a group of patients who are poorly educated because they've been trained to look for videos. On the other hand, we cannot stop that tide. And
Mhm.
so the more short form video we have, the better. I have a new short form video masterclass called IC 101. It's based on our book, IC 101. Right now, there's 19 episodes. I've got about 20 more episodes, 5-minute blurbs on different topics. So we've got some real thinking about how are we going to reach patients in 5 years and what are their expectations going to be? Because I'm worried that we're going to lose a lot more to really, really bad social media content and poorly run groups and biases and companies selling stuff. We have to work together to counteract that. We all need to be putting out videos and blogs and stuff like that.
And sending people to the icnetwork.org. This is how
Thank
we
you.
collaborate. This is how we work together. And we just keep amplifying the voices that are the voices that are going to move things forward and not cause others and groups harm.
And yeah,
100%.
I want to make you guys offers. Listen, because I have the largest support group in the world. We've got tens of thousands of members right now. Um, I'm always looking for content. I'm always looking for tips. I'm always looking for physical therapists who want to share their expertise. So if there's ever a topic that you think is important that needs to go to these patients, let's work on it together. And if there's something that I can do for you, or if you have a patient that is really, really struggling, that's what I do all day now. My staff handle almost everything else. I do patient coaching. And 95% of the time, it's completely free. All they have to do is call, and I answer the phone, and I'm more than happy to work with them. If it's longer, they want to spend a lot of time, I might ask them to sign up for a coaching, and that's like $50. But the vast majority of the time, it's completely free, and I never turn away anybody who's crying and upset, ever, ever, ever.
Thank you. And I know people within this group will definitely take advantage of all of that. Thank you so much for your time, your energy, and everything you bring forward into this very challenging, complex, beautiful world that the more we know, the more we don't know, but the more we find out, the better we get. And I appreciate it so much. Thank you again, Jill, for being part of this.
You're very welcome. Thank you for inviting me.